Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Welcome to the Mad in America podcast. My name is Samantha Lilly, a science writer and global mental health researcher here at MIA. I'm so excited to share with you our most recent spotlight interview with Dr. Ursula Read. In this episode, we'll be discussing anything and everything concerning rights-based approaches to mental health care. That is, how can rights-based mental health care be made more efficacious? Can certain approaches be replicated across cultures? And in what ways do our perspectives in the global north misunderstand and misrepresent practices in the global south, especially in Africa and particularly in Ghana? Thank you so much for listening, and please enjoy. Ursula Read is a research fellow and associate at King's College London. She holds a Ph.D. in Anthropology from University College London based on an ethnography of family experiences of mental illness and help seeking in Ghana. Currently, her work centers itself around both global mental health inquiry and participatory research methods and ethnography. With a geographical focus in Ghana, she explores the experiences of mental illness and social exclusion in the region. She has helped articulate the efficacy of the mental health care interventions in the region, as well as identify areas for improvement to better enact rights-based approaches to mental health care. She does this with the aid of those she works with and with a critical eye turned toward global mental health, what global mental health is, and what it can be. Some of her recently published work includes her paper titled Exploring the Potential of a Rights-Based Approach to Work and Social Inclusion for People with Lived Experience of Mental Illness in Ghana, which exemplifies how those of us in the global north and high-income countries overlook what rights-based approaches to mental health care may actually look like. She also is concerned deeply with the structural and social determinants of health and mental health and their interconnection with community resources, places of worship, faith, and overall health promotion. Hi, Ursula. How's it going?
Hello, Sam. Thanks for having me.
Absolutely. We're so happy to have you here. And I guess just to jump right in, it would be really lovely if you could tell all of us here at MIA and our listeners of this podcast, just to tell us a bit about yourself.
Thank you. Yes, I'm a researcher at King's College London, and I've just started working at the University of Warwick on a new study looking at the developing a new model of community-based mental health care, which will be incorporating traditional and faith-based healers in low-income communities. But I guess what was kind of missing from my introduction was really to talk about how much I work with my colleagues in Ghana. And I would like to name some of them because we've worked very closely together over many years. I worked, first of all, with Solomon Nyame, who's a researcher at Kintampo Health Research Centre. I'm also work with Lionel Sechi, who's a Ph.D. student at the University of Ghana. Dr. Lily Poby and Dr. Annabella Osetutu are the two academics that I work with at the University of Ghana as well. And so all the work that I've done has been with them. And I must also mention Dr. Victor Doku, who was a psychiatrist from Ghana, who I met in London at a conference and was the whole reason I ended up in Kintampo, because he was working in this Kintampo, which is a town in the middle of Ghana. And he was doing an epidemiological study of psychosis through the Health Research Centre, which is based there. And so that opened up a whole new field site for me, which I would never have gone there were it not for his work there. And so I feel like, these are the people that I've worked with and that have enabled my work. And I'm very grateful to all the people in Ghana who've worked with me and have supported my work over the years.
And so I guess with all of the conversation about Ghana and all of the incredible people that you've just mentioned, I guess could you just tell us a little bit more about what led to your geographical interest in Ghana specifically, coming from the UK?
Yeah, it's a really good question, and I often think, what was my right as a white British curious researcher to go to Ghana? I initially trained as an occupational therapist. That's sort of how I ended up working in the mental health field. And I was working in London, in parts of London with a high sort of overrepresentation of people of African and Caribbean heritage in the mental health system in London and in the UK generally. And it's been a big question really as to why that might be, and various hypotheses put forward towards that. Obviously, racism plays a big role, and structural discrimination and inequalities generally. And so that kind of opened my interest in how did mental health services operate in a country where there weren't many mental health services. I mean, in the UK and in America, we're very used to thinking of psychiatry as this big kind of monolithic kind of organization that has a lot of state-sponsored power to kind of incarcerate people against their will and medicate people. And of course, there was, a lot of protest against that, a lot of resistance from, organizations like MAD in America and other, the World Network of Youth and Survivors of Psychiatry. So, but that, I was kind of interested to think about what happened in those places where psychiatry wasn't so dominant, where perhaps people made more use of traditional and faith-based healing, and where there might be different ways of thinking about mental health and what mental illness is, and how you might help people with those difficulties. And so, I was working alongside a lot of nurses from Ghana. As I said, I met Victor Doku, a Ghanaian psychiatrist. And it was those kind of networks really that led me to think about Ghana as a place where I could do that research. I think another big kind of question that was being discussed at the time that I was starting my research, which was kind of in the early 2000s, was the WHO studies of schizophrenia, which have kind of many people have interpreted as showing a better outcome for people with schizophrenia in the developing world, as it was then called. And that interpretation of the results had really been a topic of quite some discussion around why would that be? If there were fewer mental health services, why were outcomes better? And there were some debates as to whether outcomes really were better, whether that was just a misinterpretation of the results. And so I was very interested to kind of explore those questions really, to see, whether that was indeed the case, and to use the method of anthropology and kind of occupational therapy in a way, looking at this very minute level. How does mental illness affect people's everyday lives, their relationships? How do they get help, and what sources of support do they have in their communities? How do they make meaning out of what has happened to them? Those were the kind of questions that I was really interested in. And what was the efficacy of these other kinds of healings? I wasn't going to do a randomized controlled trial to find out, but I wanted to kind of try and get an idea about what did people find helpful from their own point of view of using traditional and faith-based healers. Yeah,
absolutely. No, it really sounds like I always get a little excited, or like my eyebrows raise just a little bit whenever I hear really incredible academics use the word curiosity as a description, because I think that at the end of the day, a kind of compassionate curiosity is really the driver of us all. And I think with this idea of compassionate curiosity in mind, especially like in the early 2000s, when you're really starting to get engaged, at that time, what was your favorite research hat to wear? You began as an occupational therapist, and then you started, it seems, to oscillate through different roles. And I'm really curious in this compassionate curiosity sense to know what your favorite hat is, and what your favorite role is then and now, and if it's changed and circled back around.
Yeah, it's a good question. I mean, I started off, as I said, I'd worked in health and social care before, and then I trained as an occupational therapist, and I was working in hospitals and community services in London, and it really had a massive impact on me, really, to think about my own mental health and my own how I made meaning. And I come from a religious background as well. My Christian family and faith was very important in the way I was brought up. So all those kind of big questions. The method of occupational therapy, I like the way that it thinks about illness not as your pathology, but as how it impacts on your being in the world. And that I think is to me very, very potent. So it doesn't really matter what your label is. It's just more about how is this affecting you, and what can we do to support you for you to live the life that you want to live. And so I still have that kind of hat, and it does inform the way I approach my research. But I think anthropology kind of gave me the tools to think about those ways of being in the world and how they vary, and how so many of the assumptions, that we have about that we make about what feels right, and is defined by where we grow up and how we live, and how much that can vary. The way you can think about something that's very simple as, not simple as what it is to be a human being, how much that can vary. And so it gave me those tools and the theory to think about some of those big questions. The other kind of crossover, I guess, between the occupational therapy and anthropology is around the method. And the method is to be with people and to participate in what they're doing. So if I was being an occupational therapist, I would go into the kitchen with people and cook with them and see how, for example, if they had cognitive problems, memory problems or problems with focusing or attention, how that impacted on how they prepared a meal. When I do that, when I'm doing my research in Ghana, then I'm going with people in the kitchen and I'm looking at the same questions, but I'm not looking at it with a kind of clinical aim to think, okay, so how can I, what support do you need to make sure that you're getting, a meal? But I'm asking the same questions about how the illness has impacted on that, but I wouldn't necessarily be thinking of how to ameliorate that situation. That would be more to do with the people who are their supports around the family or the mental health workers or whatever. So that's sort of very kind of detailed, everyday, being alongside, understanding what it means physically and bodily to be in these kind of spaces as well. That same method, the ethnographic method of doing something in a naturalistic way and having conversations with people, I find that an incredibly powerful method. It's not unique to anthropology, of course. So, I think that method really enriches the data that you're able to gather as a researcher, aside from, the interview space, which is a kind of performative space, isn't it? And very constrained in some ways.
Totally. No, it really resonates me with what you're saying in particular about the way that doing the occupational side of things, how it really allows you to approach them centered within their humanity in the way that I think often anthropology, especially coming from the global north to the global south, how that can really impose almost a performance on certain things, and how the amalgamation of the two, and obviously correct me if I'm misunderstanding, they can enrich the experience in a way that allows you to be situated, at least for moments, alongside them, rather than hypothesizing from a chair from nowhere, or taking, Durkheim or famous anthropologists along with you in their theory and only looking at them from that scope, but being there with them in their scope, I think is really wonderful.
Yeah. I would say, that was the anthropological method was to go there and be there and learn the language and be alongside people. But of course, anthropology's history is a colonial history as well, and so there were all those kind of power dynamics, and I carried them with me to the field. I was obviously a white woman in a black space and in an African Ghanaian space, and so that presented all sorts of questions for me to deal with as well in the field, and those are still issues that are present for me today as a researcher, to think through how those power dynamics work out in the field.
And so I guess moving along in that same vein, then, could you discuss a little bit about the different kinds of power at play being in these research and clinical encounters? How do you see them change across cultures, like when you are based in the UK and when you are teaching or when you're speaking with people? In what ways do you mediate this power? And does it change differently? And ought it change differently if it doesn't?
I think when I began my research career, I think I put my foot in it a lot. I think that's, reflectively, you can see points where, if I was going now, I wouldn't go about it quite that way. I was very fortunate, as I said, to have kind of mentors and colleagues who were Ghanaians doing research in Ghana. And so, it's very much me learning from them and working with them. But also thinking about what thinkers, what ways of thinking through these questions could be of benefit. I think maybe I can illustrate this with an example.
Please do.
Because I think obviously for many people in Ghana, psychiatry, the vocabulary of psychiatry, and I think we may talk about this a bit later, but it's some of it is quite new. And I think sometimes I feel that the medical model can, for many people, be a way of making sense of their experience that takes out a lot of the kind of moral judgments that can come alongside ideas of what mental illness is. Often it can be linked to ideas of, taking drugs or doing something spiritually questionable, like witchcraft, or being cursed, or all these kind of connotations which can be very stigmatizing. And so a medical model of mental illness, for many people that I know with lived experience of mental illness in Ghana, that means that they can not have to deal with all that kind of stuff and find it's a more neutral way for many people of thinking about it. I've got an illness, just like any other illness, and I can take medication for that. Now, obviously, I know that from, the history of working in mental health services in the UK and knowing, what I've read from the US, and, that many people with lived experience in those settings have contested the medicalization of their experience, because it's actually in itself has been stigmatizing and has also sidelined people making sense of their mental illness through spiritual language or ways of being. So I think what's nice is that there is space to kind of open up this kind of conversation of thinking about different ways of making sense of experience and bringing people into conversation across these geographical boundaries to kind of, because the question of what mental illness is still unresolved. And the kind of things that are often presented as certainties, in the Ghanaian context, I see sometimes, that education around mental illness often presents things as certainties, and that, we like certainties, and public health messages, supposed to be clear and kind of, and not. But of course, for me, what's interesting about mental illness is that it does have all these uncertainties, and it does, it still is an open question exactly, what causes what we call schizophrenia, and and even schizophrenia as a label is, many people would argue that we should get rid of it. And so I think I'm going about this in a long way, but I'm kind of saying that there's a space for opening questions. And I think that sometimes, when I remember going in Kintampo, giving a lecture in the College of Health there, and just telling people actually about some of the experiences that I'd had in the UK of patients, being very unhappy with the medication they were taking and looking for alternatives, and mental health workers trying to work with people to see how, they could reduce their medication and come off their medication and find other paths to recovery.
Do you find that in Ghana there's a desire to be, because of the stigma, the moral stigma in particular, of potentially having abnormal behavior or something that would present itself as schizophrenia in the global north? Is there a desire for these individuals to say that they have a mental illness? Like, are they asking for a label? Are they asking for medication? Is that something that you've experienced?
Yeah, I feel I'm slightly uncomfortable talking on behalf of the people, but I think there are many people that I've spoken with in Ghana for whom receiving a diagnosis has been a big relief, because they have been going through these experiences and not really knowing what's happening. And, it's caused all sorts of problems at work, in daily life, in their relationships, their families. And, getting a diagnosis, talking with a psychiatrist who can help them to make sense of some of what's happening within that medical frame has actually been very, very helpful in a time of huge confusion and distress. Nonetheless, I think it's true to say that many people I meet are very unhappy with the medication. And we all know that, the drugs that are used to treat psychosis in particular have really terrible side effects and really problematic. And people find that they're sedated, they're sedatives, so they're sedating. They can impact on your sexual performance. They can make people feel cut off from their emotions. So people wrestle in the same way. And I think the idea of taking medication indefinitely is also horrific to many people. The idea that you have to keep taking these chemicals for years on end. And through my practice as an OT and my practice as as a researcher, I've sat with people who have been really devastated that they stopped taking the medication, and then they had some terrible symptoms, hearing voices or something, or really frightening experiences. And then, feeling, God, is this it? I've got to kind of keep taking these meds, and it's really difficult. And I think there's a real need to have honest conversations about these issues some people have also queried, the level of research that goes into treatments for mental health is nothing like at the same level that it is for physical conditions. So there's a very limited options, really, even in terms of something as basic as medication. So in brief, I think, the medical model is helpful for some people to make sense of what's happening. But I think what's not helpful is when that kind of drowns out other ways of making sense of experience. It sort of erases all the questions, all the unresolved issues, the issues that are still being debated and researched today. Then obviously, to go back to those questions of power, medicine has massive power compared to other ways of approaching mental illness. And you can see that, even on health systems that are funded by international aid organizations, by local governments. They fund medical health systems. Right. They fund psychiatry, they fund psychology, perhaps sometimes. They don't fund traditional healers. They don't fund faith-based healers. That is not sponsored by the state. Those are private enterprises.
The reason why I ask is because in my experience in countries in the global South, I feel often it's as though some of the talking points from folks that really, really believe in the medical model could help them, and not to say that it won't, but it does feel like the globalization and exporting of psychiatry to the global South feels really, really challenging, in particular to then understand what are other ways of meaning making when we're telling people all across the world, we being global superpowers in psychiatry and psychology, that the biomedical model is the right model. And I would love for you to explain or give an anecdote about how there are other ways of meaning making, in particular in faith-based practices, and that aren't funded by all of these quite insidious enterprises.
I think it's important to remember that, of course, places like Ghana and Nigeria and other countries, they have their own histories of psychiatry. Psychiatry has been around in Ghana, for over 100 years. It's their own traditions of how that has come to be, starting in the colonial period, and then, of course, in the post-colonial. There are 3 psychiatric hospitals in Ghana. 2 were built in the post-colonial period, and thinking. People were thinking at the time of, like new models of mental health and what, something that wasn't like a colonial asylum, that wasn't like a prison, but was more like a therapeutic kind of space. So it's important that we don't just think of it as something that's been exported from the north and, taken to the south. To go back to your question, I think, it's interesting, I think, working in Ghana, because so many people, faith is so important to them. And so even, someone that you can think of as the most diehard psychiatrist will also go to church on a Sunday, and not just go to church on Sunday, but pray every day, read the Bible every day. That the faith is present in ways perhaps that for many people in the US and in the UK, it isn't. And so even when people are working in psychology and psychiatry and mental health as mental health nurses, their faith is also there. So I think this is one of the things that facilitates working alongside traditional and faith-based healers as well. I think there is a lot of respect for the work that some of these people do. There is also a healthy kind of critique, because there are healers who are very exploitative. And obviously there are a lot of concerns about the use of chains and shackles and other restraints. So there's a lot of mistreatment that goes on in some of these places as well. So there are lots of very difficult ethical issues to consider. But I think we've been doing research looking at how traditional and faith-based healers and mental health workers are working together. And the nurses that we were working with in the towns where we were doing our research in Ghana, very much saw it as being a balance, between the two. So they kind of, as mental health workers, were offering a kind of medical framing and psychiatric drugs, and also addressing, not just doing that, but also thinking about some of the, how they could support people with their livelihoods and things like that. They were aware of the kind of social factors that were also difficult for people. Poverty is a huge part of people's lives in that part of the world. But then they also recognized, that the faith-based and traditional healers have expertise in the spiritual realm, and that they have insight into these other aspects, and that these were incredibly important for their patients in making, and their caregivers in making sense of what had happened. And this is, I think, something that really is something that we can learn from, is how these different approaches can work together. Oftentimes, not respecting each other's space. I mean, the models that we were looking at, people were not kind of coming together in the same space necessarily. There were different ways of doing it. Sometimes nurses will go and maybe do an education session on mental health and teach people about, different, how mental health can affect people, signs and symptoms to look out for, where to go for help. They might, in a church might allow you to go there and do that talk as a nurse. Mm-hmm. You could do that. And they would go and see how the patients there were being treated. And also some healers will allow them to be giving them medication while they're also doing the prayers. So this kind of way of combining medicine and prayers is, as a little medicine, a little prayer. That's a common expression in Ghana, and one that's the subtitle for our film, which will be coming out from our Together for Mental Health project. So that expression kind of, that making space for both approaches and recognizing that both of them are important, and there's sort of mutual respect, building that is one of the success factors, I think, in having these kind of pluralistic approaches to mental health.
If you could, would you tell us just a little bit more about the film, just really briefly?
Yeah, sure. So myself and Arminia Colucci, who's a filmmaker and psychologist, cultural psychologist, we got some funding from the Global Challenges Research Fund in the UK to make a film in Ghana and in Indonesia, where Arminia had worked before, to look at how mental health workers and faith-based healers are working together, and traditional healers. Yeah, so we, with Lily Poby, my colleague in Ghana, and Roberta Salome, our research assistant, we spent some time up in a town in Ghana where there were some nurses who I'd met before, who I knew were visiting traditional and faith-based healers and doing some work with them. So we kind of went with them to visit. They introduced us to the healers working in their area, and we looked at how they were establishing these relationships. And what different ways they had found to establish these collaborations. And Ghana's been very innovative in this respect, because their Mental Health Act, which was revised in 2012 from a sort of rights-based approach, one of the aspects of the act was around working with traditional and faith-based healers, so that the shackling and chaining, that could be reduced and eventually eliminated. So as part of that, they've given a lot of backing to setting up these kind of collaborations, and we're asking community mental health workers to do that. So they have published a policy on that, and so so the big challenge for nurses, as in many countries, is the lack of resources, really. So a lot of the time, these collaborations, visiting healers who live miles away, it needs transport, and they don't have transport. And they don't have money for fuel, even if they did have transport. They may not have medications. I mean, getting medication. I mean, that's the funny thing, in a way, that people worry about kind of over-medicalization of mental health in the global south, but actually getting hold of drugs, pharmaceutical drugs, it's a real problem. It's very expensive. They should be free, but they're not available often. So they face a lot of these kind of resource challenges, but the people that we followed, incredibly resourceful in finding ways of getting around these challenges, raising funds, digging into their own pockets. So the films they're in the final stage. The Ghanaian film is in the final stages of editing, so it should be out later this year. So the project is called Together for Mental Health, and you can follow us on Twitter and other social media pages. Very excited to show that film when it comes out. Yeah.
And just as like a segue back into the formal part of the interview, but also just out of my own curiosity, what for you is the ideal outcome of the film? Is it to complicate our understanding? Is it to share stories? Is it a mixture of both?
The idea for the film really is we wanted to set up kind of an exchange of experiences and knowledge between Indonesia and Ghana. I mean, that's one of the things that has happened, and it's been really great to bring people together from these two countries who are facing similar challenges in terms of the concerns about human rights. And in Indonesia, it's called pasung, the use of restraints and cages and things that are used to restrain people who are considered to have mental health issues. So it's been really great to establish that network. And then also the films we hope will be used for education, for awareness raising, for starting these conversations about how can these collaborations be set up, how do they best work, what are the factors that make them successful. So they could be used for training health workers, for example, who want to do these kind of things. And I think, I think there'll be real interest, in the UK, in the US, because I know projects, in South London, for example, where I live, that, where there are a lot of Black churches and people want to think about how mental health services can come together with people in our Black communities in the UK to work together and bring spiritual approaches more, to consider spiritual approaches to mental health and the sort of social aspect, because in Ghana too, that's what we see, is that these faith-based, they're called prayer camps, where people can go and stay. And often, they are spaces where caregivers in particular can come together and share their experiences, meet other people who've been through similar circumstances, and they support each other, in very, very difficult situations often.
It's wonderful. It inspires me to ask a little bit further just about the experiences, and in particular, you had recently written a piece in a limited series called Psychiatry Beyond Phenom that references a little bit about the caging that we see from the US and the UK and the photographs that we're given. And I know personally from experience the pasong in Indonesia and the caging of individuals there as well. And I guess, would you tell us more about this specific piece and in particular, like the series writ large?
Yeah, I mean, the series was it was edited by Matthew Heaton, who's a US historian of psychiatry, but he wrote a very great book called Black Skin, White Coats, about the history of psychiatry in Nigeria. So really the series has published different short pieces. Africa as a Country is a blog, an online space where Katie Kilroy-Marek, for example, had written based on some of her work in Senegal about within the French colonies used to send people back to France for treatment from Africa. And it's a really terrible stories of people who were just, uprooted from their country, sent to Marseille and died in Marseille, in the asylums in Marseille. I mean, so it's kind of trying to shed light on some of these histories. I mean, the inspiration for that piece really came because there was an article published in The Guardian, which is kind of the UK's leading kind of progressive newspaper, I suppose. And it had a lot of these pictures of people in chains in Ghana. And a whole sort of photo series accompanied this article. And, it was talking about Ghana as like a mental health void where, there was just no access to psychiatry and people were chained up. And I felt very disturbed by that piece because I felt it presented Ghana as if nothing had ever changed there, that there were absolutely no mental health services whatsoever, that, everybody was just kind of, it was like a kind of in the dark ages, primitive and just in a stasis, all those sort of tropes of Africa as being, backward and out of step. Nothing changing. So I had, back when the article was first published, I got together with a load of people in Ghana that I know, the head of the mental health services there, and loads of people. And we wrote to The Guardian and we said, look, there were actual, there were facts in there. There were misrepresentations of facts, like the number of psychiatrists was wrong. And, so we corrected those and we said, we felt it was a misrepresentation, and Ghana had really expanded the number of community mental health workers quite dramatically over the last 10 years. And, while we felt, we understood the need to highlight these injustices, we felt there was a bigger story to tell. So the Guardian completely ignored our letter, which I felt was quite shocking, given that, had the head of psychiatry in Germany, for example, written to the Guardian, would they have ignored it? I don't know. But anyway, it was Ghana, so they did. So that was the kind of inspiration for the piece. So it became this piece for Africa as a country. And I just wanted to shed light on what had changed in Ghana. And I've been working in Ghana since 2005. So I've been able to see that firsthand, how the number of, Kintampo, where I did my PhD, when I went there was not one mental health worker in that town, and quite a sizable town. And now, there are tens of mental health workers in that town and in the villages around, So it's a really dramatic change, and it means that mental health care is a lot more accessible. And, in the place where the images were taken, Stephen Asante, who's a mental health nurse in Tamale, a city in the north of Ghana, his salary is paid by Ghana Health Service. He's a state employee. He works for the State Health Service. He's also set up his own NGO. He is there, helping to free people from chains, getting them treatment. So I that was what I wanted to kind of highlight, really, that there is these stories that don't get told. They're not so dramatic,
right?
And they perhaps don't fit with people's stereotype and with, I suppose, the ways that those kind of images are used to appeal for funds, aren't they? So images of starving black bodies, chained black bodies, but they risk replicating these stereotypes, right. And replicating the power dynamics where it's kind of, the white savior complex, that they're sort of waiting for someone to come and rescue them, rather than actually Ghana. Many Ghanaians are deeply troubled by these issues and are fighting very hard to make sure that nobody is chained in Ghana anymore.
Right. They don't need this voyeuristic misrepresentation of their work and what's being done. And I feel like it especially gives me pause, because in replicating these stereotypes, it then also replicates as well, just like the complete misunderstanding of I think, faith-based healing not being something that works. Because if this country has faith-based healing but look, they're still chaining people. Do you think that it does an injustice to the kind of spiritual and faith-based work, these kinds of images? Because up here in the US, when we see mental illness and we see people caged because of their mental illness, of course, our natural thing to reach for is medical intervention, not necessarily faith-based intervention.
I think it's important to say that, of course, I've met many people who have been chained or are chained in Ghana, and it, it's horrific. And I don't want to in any way minimize the suffering that people have. But I think that is not the only story, and that there are other people I have met who faith-based healers who genuinely care for the welfare of the people who come and use their services, and do a lot to try and support a very stigmatized group, actually. And that's the thing, that they're often working with people that, other people don't want to work with. When we were doing the film, we went to visit a pastor in this town, big market town in Ghana. And, walking into that compound, there were many young men, predominantly, in really serious distress, some very angry, shouting and being very abusive to their family members, their mothers. It's usually the mothers who are staying there with them, insulting them, shouting at them. And you can see just how difficult it is for the families in those situations when they're facing a crisis, really. And I felt it really struck me, because it was like walking onto an acute ward and thinking, but a space where, there were no places to have time out, no sort of, nobody's been trained in de-escalation. It's kind of, so people are having to deal with this the best way they can, and in a space that's not very safe. There are knives, there are rocks, there are all sorts of things, fufu pestles for pounding fufu. These are all things that I know have been used as weapons, and I know those stories, and I do know people, mothers have been killed. These are things that are not common in psychiatry, but to pretend that doesn't happen is also to ignore that does. There are things that happen, and they are tragedies. And of course, it's a terrible tragedy for the person who is experiencing a mental health crisis and commits that act. Everybody wants, because they have to live with that for the rest of their lives. And so people in Ghana have expressed to me that they feel that in some ways, they are making up for the lack of mental health services, because there aren't enough wards for people to go when they are in acute crisis, or safe houses, or places where, whatever model you want to use, those things are not there. So the churches and the shrines are often filling that gap by holding these acute cases, and that the upshot of that is, of course, that people can get chained. So these are really difficult questions for all societies. And when you were talking, I was also thinking about the really horrible situations that happen on wards in our countries, in the UK, in the US, and indeed in Ghana, where people are forcibly held down and forcibly injected or given ECT without anesthetic. These are all abuses in one way or another, and some of them we justify them, but we don't work hard enough to find other ways of approaching these situations. Here in the UK, you can still, of course, our Mental Health Act permits you to take people against their will to hospital. And in an ideal world, we'd want to find some way where that wouldn't be necessary. And oftentimes it ends up, I think we're at a bit of a crisis point at the moment, actually, because the cuts in mental health services mean that it's much more likely that compulsion will be used, because people are not getting supports in the community and things get to crisis point. And then, then it's much more likely that you're going to use the Mental Health Act to bring people into hospital. I think that's in my work, in a way, that's what I like to do, is to try and think of these as like kind of, they're big issues for all of us to grapple with. And I think that we are all learning together how to deal with these central problems of being human. And
absolutely. I think all of the issues that you had just described across all of the different cultures and communities that we're talking about can easily be described as some kind of human rights abuse or a neglect of human rights. And I think we so often hear nowadays the boasting of rights-based approaches to mental health care. I'd love for you to define rights-based mental health care for our listeners, because I think it's often something that is really difficult to define. And so how is it defined to you in your work, and how does faith-based healing fit into rights-based approaches?
Yeah, it's a really good question, because I think, rights has become one of the sort of central kind of discourses in mental health, and WHO and World Health Organization, the UN, there's a big push to improve rights in mental health, but often we tend to think of rights very much in these kind of freedom from abuse, right? So, and particularly perhaps when we think of countries like Ghana, that we think about it as a rights-based healthcare is getting rid of the chains, getting rid of the restraints, improving access, the right to health, right? So improving access to mental health services, evidence-based services. What we tend to focus less on is what have been called like positive rights, or there's the sort of rights to be included. And the research that I've been doing with the Wellcome Trust, the Mental Health and Justice Project at King's, is around Article 19 of the CRPD, the Convention on the Rights of Persons with Disabilities. And that's looking at the right. Article 19 talks about the right to live independently and to be included in the community. And, when we think about rights-based healthcare, mental health care, we often don't think about that. We don't think about the right to have a decent job, the right to a family life. A lot of people that I know with mental health issues, they don't have kids, they don't have, they're not married. And in a culture like Ghana, that's really quite unusual. And yeah, I've met women who their children have been taken away from them because they have a mental health problem and gone to live with a father's family, so these are all rights issues. And And I have to say that, there are some great NGOs in Ghana who are really doing a lot to push on rights, and civil society organizations. It's interesting, actually, because organizations that have been focused on gender equality, for example, domestic violence, these kind of issues, they've become involved in, in seeing these through that these are also issues that are relevant to mental health. Yeah, so a rights-based approach would be looking at these issues around social inclusion, around participation, around creating enabling environments where whatever your issue is, whatever disability you have, that you have the supports that you need to make decisions about your care, to live with who you want to live with, to work, to have a meaningful role in society. I think the complex issues are around that these rights are often, even if you don't have a mental health issue, are often not available to people. And there've just been big protests in Ghana because there's huge, youth unemployment. There are just not the work opportunities. There's rising inequality in Ghana, as there is all over the globe. And obviously in the pandemic, that has really increased those inequalities. And so I think we really are at a very critical point, actually. We're also, another project that I'm working on is thinking about how to have, after the pandemic, well, during the pandemic and in life, hopefully after the pandemic, how to, have a more disability inclusive recovery, where we don't just sort of go back to normal, but that we think about how services can and how societies and communities can be more inclusive for everyone and be more accepting of difference. And I think that's what, as human beings, we're not always very good at that.
Right. And especially when those differences we perceive or we're told are a cause internally within ourselves, whether it be in Ghana in a more moral, spiritual way, or whether it be in the US and the UK in an illness way. The blame still falls onto us when I think, and I really appreciate you saying it so directly, it's often such a social determinant as well. And one of my favorite catchphrases, or turns a phrase that I've coined it now. I'm certain somebody else has said it before me, as suicide is a social justice issue, meaning that people aren't just killing themselves, where we have, it is an inequity. And I really appreciate you saying that so frankly. And so just to wrap up, I suppose my last question would be this, which is, how do you believe that we can continue to move forward with global mental health in a way that is most ethical and efficacious, especially as inequality rises and especially with the history of global mental health as a field?
I think the big question for global mental health is, there are two kind of big questions, really. I think one is around kind of decolonizing global mental health and shifting the power dynamics. I mean, at the moment, it's so frustrating because most of the way the funding networks are set up, typically it works, and this is how all my projects are, that the funds come from the UK, from funders in the UK, and then they get sent to our partners in the global south. And of course, that just totally retains, it's a really colonial way of doing it. It means that all the kind of governance strategies, all the funds, it's all flowing one way, and that's just not right. And that really has to change. And we need to see the funds, funding sources coming up within countries so they can, fund their own research, fund their own researchers without it having to come via institutions in the north. So that's something I know that other people in global mental health, I know that Melanie Abbas at King's College London recently wrote about this. So I think this with some colleagues. So I think these are really important issues. The funding, how funding is set up and how it's organized and where it comes from. That really has to change. I don't want to be the principal investigator for my research projects without having principal investigators in the countries where I work. Who, that's just not right. So that's one of the things that has to change. I also think that global mental health is such a misnomer because it's not really very global. It's very focused in certain countries, often former colonies. So, it's no coincidence that Ghana is a former colony of the UK. That's where I work. We have these close relationships. There are lots of Ghanaians living in the UK. These are colonial histories that have informed those migration patterns. If you look at global mental health, a lot of it is based in Anglophone countries, and a few of those. So, you've got kind of places like Uganda, South Africa, in talking about the African continent. And there's just huge swathes of Africa that just never get, no research really is ever published. And if it's not in English, nobody reads it. And so there's all these kind of, so I think we just need to, global mental health needs to really sort of think about where research, and when we talk about Africa, are we really talking about Africa? And Africa is not a country,
right?
And to recognize that kind of diversity, and also to think about the inequalities in our own countries. And global health is often seen as, the global is everything that is not the North, right? It's not the West, or whatever we're going to call ourselves. And so, I think we should be able to turn the lens on the so-called global North, and to have, I'd love to see Ghanaians coming and doing research on the mental health system here, or on faith-based and traditional healers here. That would be great. Someone who doesn't live here to come and cast that eye and tell us about ourselves. That would be great. Come and ask some questions about the way we do things. That's what's got to happen. It's just got to be a much more equitable playing field.
Totally.
Yeah.
I love that so much. The last thing that I want to just open up to you, is there anything that you want to share that we didn't get to touch on with my questions?
The questions that people often ask me, one is, so what is your research going to do to help us, to help Ghana? Which I always think is totally the right question to ask. The other question is, more of a personal one. It's like, how can you support me? How can you help me? I need medication. I need, I want to get a job. I need to earn an income. These are the kind of questions. So I think that is the question for all of us who work in research, and I think, we started talking about different hats, and I think because I have worked in mental health services and I know there are things that can help, I think, it's often not enough to just sort of intellectualize around these questions and theorize around these questions, but also it's also not satisfactory to just export models that we have and scale them up and expect that they're going to work. We have to kind of be humble about what we know and really listen carefully to what people are telling us about what might help or what they know, because everybody I've spoken to in Ghana are experts on their lives and on what's happening to them, and so my job is to listen and learn from what they tell me, and hopefully I try to kind of share some of that with people in Ghana, but also outside. So thank you very much for having me, Sam.
Absolutely.
Really interesting questions.
No, absolutely. And I think you did a wonderful job. It's evident that you listen, and we're really grateful that you were able to share with us all that you have. So thank you.
Thank you, Sam.
Thank you for listening to the Mad in America podcast. Visit madinamerica.com for more news, views, and updates.